Hello, everybody. Welcome to the first spine weight connection seminar. My name is Mark McLaughlin. I'm a neurosurgeon in the Princeton area, and I've been taking care of patients with spine problems for 25 years now. And I invited my colleague, Dr. Seun Sowemimo, and I'm sure I mangled his name, but we're going to go with that for now, to be our guest tonight to talk a little bit about weight, obesity, and just weight control problems and how they affect your spine. And I just thought it would be great to have a doctor conversation about how we commonly see patients that have overlapping problems. And I invited Maggie Fitzpatrick, our medical student extraordinaire, to help us navigate these waters, and also to add a medical student's perspective on this. So, Dr. Seun, we're so glad to have you here. I just so the audience knows, Dr. Seun is a minimally invasive bariatric surgeon who's trained in robotics as well. He trained at Columbia. He's been on the Dr. Oz show, and he has a very robust social media presence, educating patients and serving patients with respect to weight control and weight loss surgeries. And it's great to have you on today, Seun.
Well, thanks, Mark. It's great to be on with you. And thanks for the glowing introduction there. I've been here in the Freehold area just serving patients over the last decade or so, trying to help with the problem that we have nationally with obesity in my own little way, with bariatric surgery, but more than that, with as you mentioned, the education of our patients in terms of weight loss, in terms of, what they can do to mitigate the problem for themselves and save themselves, from having issues with this. And I do see quite a bit of overlap with patients that I'm sure you see with spine issues, that have as a contributing factor the weight. So I'm happy to be here with you. I'm happy to talk about the subject, and looking forward to getting into it.
Yes, one of the most interesting things I find about bariatric surgery is that it's actual surgery that reverses a disease process. I mean, obesity affects so many different organs, including a person's lifestyle, their bone health, their muscle health, their cardiac health, their lung health. And it's got to be a remarkable feeling for you to give somebody their life back in a very, very special way.
Absolutely. I mean, this is one of the things that actually drew me into the field, Mark, because when I was coming up as a resident, one of the things that really, got me thinking was that bariatric patients were big patients, right? No pun intended. But we could do surgeries that were minimally invasive, very small incisions, and actually reverse that. And what it does is that in the same way that weight affects every aspect of patients' lives, everything from, how they sleep, you got sleep apnea there, socially, being able to go into a restaurant and feel comfortable, even just get into your seat, or whether they're going to put you in a booth or something like that, to, the most intimate things, cleaning yourself up, not being able to reach, those kind of things. So it affects every aspect of life, and then life itself, in terms of affecting the mortality of our patients. So the fact that a surgery could have an impact on all those things was really fascinating to me. But it is because what we eat has an impact on our health. Your body is always trying to heal itself. And, what we eat has a big impact on that. So if we have a surgery that has a big impact on what we eat, then that would have ramifications all throughout the body. And what I try to add to that is it's not just bariatric surgery affects the quantity really of what we eat, and then it gives us a metabolic process as well that helps us along, makes your body itself want to lose weight. But we can add to that changing the lifestyle, doing the things that support weight loss on their own in terms of diet, especially, and to a lesser extent, and I know I'm saying this is not cliche, to a lesser extent, exercise. But exercise is also important, but the impact that the diet has on weight is certainly more than the impact that exercise has on weight. And we'll get into that a little bit more, but it was one of the big fascinations for me that you could use a surgery to impact so many different facets of a patient's life. That's one of the main reasons that I became a bariatric surgeon.
Why don't you give us just an overview of the options that your patients have when they come into the office and you deem them a candidate? I would imagine, first of all, you have a number of patients that you see that you don't feel are candidates for bariatric surgery. Maybe they don't fit the criteria and they would be better off with another modality. So give us just an analysis of, when you see a patient, what you're thinking about and how you go about assessing them for the types of procedures that you do.
Right. So a lot of this work has been done before in terms of we have fixed criteria based on BMI that qualify people for surgery. So, and it's been certified by the main societies, including our society, the American Society for Metabolic and Bariatric Surgery. So BMI's body mass index, right, that is more than 40 qualifies for bariatric surgery. Also, any BMI that is between 35 and 40, if there's the presence of any of the significant comorbidities that we see with obesity, like sleep apnea, type 2 diabetes, high cholesterol, arthritis of weight-bearing joints, spine, knees, hips, those sort of things, also qualify people for bariatric surgery. The reason behind this sort of tiered qualification process is that at different levels, conservative therapies can work. If people are just overweight, conservative therapies, diet, exercise, behavior modification can work in reversing that. But the more the weight or the BMI category, once you get into obesity, or you get into the severe obesity above BMI 35 or morbid obesity above BMI 40, the percentage of people that will be able to succeed in reversing their weight and losing weight on a long-term basis with those conservative measures, tends to dramatically fall. So then this is why you need a bigger tool, a more robust tool like bariatric surgery to help those individuals. So with bariatric surgery, we go from maybe 5% of people that can lose weight with a BMI over 40 on conservative therapy. You go to something like 70% of people will be able to lose that weight and keep it off. It's still not 100%. And that's where, it comes that it's not just doing one thing, using one tool. We're all kind of programmed to think about solutions in terms of find this one solution. But with weight loss, it's not a one solution sort of situation. Like most things in life, it involves doing a whole number of things right. So we kind of stack the therapy. So everything conservative, diet, exercise, and then on top of that, the bariatric surgery is the way to go.
So let's talk about patient compliance and enrollment in weight loss, because you're a surgeon, I'm a surgeon. Oftentimes we'll meet somebody once and we'll see them and we'll know that they're not a candidate for surgery and they really just need to focus on lifestyle and diet and exercise. How do you get a patient to buy in on that, especially when you've got a short period of time? And, it could be the most important office visit of their life, them seeing you and finding out what happens. How do you do it? I have a couple of things that I do with patients, but I'm curious to see how you handle a patient, especially when you're trying to get them to buy in to conservative therapy.
right. There's a number of kind of short stories that I tell. One of them is, I have kids, and two of my daughters. Once, they had the pool party. They invited all their friends, and they're having this pool party. I have my hose by the pool side, and I'm filling the pool as they're splashing about, and the water level is getting low. Suddenly, one of the kids picks up the hose, and she starts to splatter this thing all over the place. I mean, like, parents are sitting by the poolside, everybody's getting wet, and they try to go at her directly, right? And the more they're trying to go at her, the more she's swinging the thing, and everybody's getting wet. They're all screaming. I hear all this noise. So as I'm running to the pool, I didn't initially know what I was going to do. As I was running to the pool, something just hit me and said, make a beeline for the faucet. So before I got to the pool, I just made a detour to the faucet. And as I was turning the faucet off, there was a calm that just kind of descended on everything as the water in the faucet went down. And I'll tell you, there was a point in time I thought that was what I did with bariatric surgery, but I'm wiser now. That is actually what you do by paying proper attention to diet, exercise, other lifestyle changes, especially diet. That is the turning off the faucet. There's no point, no matter how good the tool is, surgery, and everything that you can apply, if you don't fix some of the primary problems, you're still going to have that water just spraying all over the place. You can temporarily try to tamp it down, but the main thing is turning off the source of the problem. And that's the way I explain it to patients.
Got you. Got you. I find that, over the years, and we both have a few gray hairs, I found that scare tactics really don't work for patients. Telling them their blood pressure is going up and they're going to have a heart attack, or they just don't listen to that kind of stuff. Sometimes I can get through to them with, do you have grandchildren? How old are your grandchildren? Do you want to see your grandchildren graduate from high school? You're going to need to do something differently if you want your kid, you want to see your grandchildren. So you got to find out what's important to someone and really kind of leverage that in the conversation, because generally just people just don't respond to the scare tactics.
I think sometimes too, especially with weight and in our society currently, there is a tsunami of, the culture essentially is like a tsunami against, losing weight. We're in an obesogenic sort of society. The kind of foods that you're faced with every day, and it's not just at mealtime, on the TV, as you go to work, you pass by, there's dispensaries of, snacks and everything. There's food everywhere at every time, and the food is made to be colorful and so appetizing and all that. So the whole society, the way we eat, the food that we're presented with today is so different from 50 years ago. So no one is coming to save you. You have to save yourself. So it's a matter of trying to educate, patients and allowing them to see that this new food situation that we have, that we've normalized, is not what normal human bodies are used to. And we're sort of maladapting to it. So you have to kind of get a reset to what was normal and understand that and be able to adapt yourself to that. Yes, the surgery helps. Yes, there are other things. You can take the medication, right? There's medication now, and you can inject yourself every week, to try and lose weight. But at the fundamental basis of it is that you got to learn how to eat, how to move in a normal way that your body is used to as normal, not what the culture dictates. And then that's where you would find some long-term results. These things that we're applying, the medication, the surgery, these are tools that help you to properly hit that reset button, but that effort has to be applied.
Let's talk a little bit about the relationship between weight and low back pain. What percentage of patients do you see that have low back pain in your office, and how well do they respond? How does their back pain respond to these types of surgeries?
Right. So I was thinking about this when I was thinking about this talk, and I don't have a definite number that, based on statistics and the actual patient, but if I was to hazard a guess, it's somewhere around a third of the patients actually have some back issues, and this is not surprising. If you look at a lot of patients, once you start becoming morbidly obese, there's a lordosis, that they have to carry that weight between the anterior aspect of their abdomen and, their muscles not supporting completely and their back. There are other issues that come into play, other joint issues that, will affect their posture, and once you're sort of out of alignment, that starts to wear on your back. And some of those problems can be, how shall I put it now, temporary and not permanent, but at some point permanent damage might occur. Of course, I defer to you. You see more of those people. You tell us, those kind of permanent, the kind of permanent damage that can be seen in these situations. But this is what I see. A lot of people just complaining of consistent low back pain. It's almost not even it's not something that they see as a main problem. They see it almost as a way of life, that they're always having, back pain, knee pain, that sort of thing.
Right. And it's a little bit of the
What do
chicken
you
and the
see?
egg.
Mm-hmm.
It's a little bit of the chicken and the egg too. When you go in with a person who has a high BMI, and they really have significant fat load on their body, their muscles, their spine muscles get fatty infiltration as well, and they're less functional. And one of the things I talk to patients about is any joint has an equal and opposite muscle. Your elbow has your bicep and your tricep. And if you go to the gym and all you do are curls for 10 years and you don't work your tricep out, you're going to have elbow arthritis because there's an imbalance there. Our joints are designed to have balance. Similarly, in your spine, we have the psoas muscles, which are in front of the spine, and we have the paraspinous muscles in the back. Maybe we should go to a slide. Maggie, can you pull up just the image of the equal and opposite opposing muscles? And so partly because of lifestyle, slide 5. So partly because of lifestyle and partly because of weight, these are the anterior muscles. These are the muscles that flex your body, and these are the muscles over here that extend it. And so for the audience, we want to exercise these muscles, and we want to exercise these muscles. Without doing that, you'll develop an imbalance and you'll develop arthritis. And there's good studies that show, fatty infiltration of the musculature causes dysfunction of the musculature, and it can lead to spinal stenosis. So many times, an obese person will have strong back muscles because they're holding everything up. They've got a gigantic 50 or 100-pound or maybe even 150-pound pannus or abdomen in front, which is pulling them forward. And as you mentioned, they may have a hyper arch. They may have a hyperlordosis to try and hold it up, or they may walk in a kyphotic posture. Maggie, show that other picture of kyphosis. So, this is the normal curvature of the spine here. It's possible they could be in a kyphotic posture where the spine is falling forward, or they could accentuate and actually arch back to try and balance. But the key to the spine longevity is sagittal balance. That's the balance of the weight from the top to the bottom. And you can see almost like a sinusoidal curve on the spine here, and the weight coming down. It's ergonomically designed when we are at optimal weight to support our torso. And so, just like a tire that's out of alignment on a car over 50 to 75 to 100,000 miles, the whole axle gets damaged. Similarly, your spine, that if it has an excessive weight burden and the load is distributed farther into the front, those joints are going to get arthritis. Or if you arch back, those joints are going to get arthritis, and those muscles don't stay strong. So, like almost, I would say 90% of the patients that I see with low back pain that have some, they're not morbidly obese, but they're obese. They have some gut on them. I start working them with a abdominal musculature strengthening with planks, which is by far the best exercise for people, better than sit-ups and better than other exercises. But it's like riding a luxury liner. It's not going to turn on a dime 90 degrees. It's going to go very, very, very slowly back on course. So it's important for people to know these exercises will work to strengthen your spine, but it takes months of effort. And like you said, turning the faucet off, which is, I think, really, really critical.
Right. Let me ask a question of you. So if someone with weight, someone that's morbidly obese, if they undertake this kind of posture, kyphotic posture, or the hyper extension, the lordosis, how long does it take before that becomes, kind of like before you start seeing like permanent damage from that? The arthritis that you talk about, what's the sort of timeline?
I would say probably within a couple of years. I don't think it's right away.
Wow.
But within a couple of years, if your spine is compensating to carry that weight, the arthritis is formed. I mean, our spine is designed to carry a normal weight load. It's not designed to carry a supernormal weight load. So the spine bones, they're shingled in the back, the joints, and if you're being pulled forward, they're going to slide more and they're going to rub more and they're going to wear out more, just like any other piece of equipment.
Yeah.
So
The reason I ask is that, that 2-year time frame is important because for me, the average amount of time that patients have been thinking about bariatric surgery before they come for the first consultation is usually between 3 to 5 years.
Yeah,
So
it's
that
probably
means
already
that,
done some damage.
yes, exactly.
So I have
Exactly.
I have a question, Dr. Sean. Do you see, or what are your thoughts now with the, obviously in the media and everything, with the GLP agonists and the weight loss, semaglutide and all of that, and the crazy effects that they're having, the rapid weight loss? What are you seeing with those in the media?
Well, it's there's two sides to this. I mean, the medications work definitely, and it's nothing magical. The medications, actually, GLP-1 is something that we have known in the bariatric community because we know that that is one of the mechanisms by which bariatric surgery works. It's one of the hormones that is affected and that is increased with bariatric surgery. So that they were able to, make that into a medication, and it's been around for a few years, but obviously became more famous with the injection version of it that you can inject a week at a time. And of course, with the explosion on social media, I'm not sure if it was Kim Kardashian or one of those people that got onto it, and then it became a thing. Maybe we should have her promote bariatric surgery too. But I kind of have mixed views about it because one of the things is that people think it's again one of these solutions that is an easy fix. You just take this thing and part of the feedback I was getting from patients is that they would use it to lose weight and then they'll come off the medication. But what the research that was done when these were coming to market showed is that if you come off the medication, you regain the weight. Because, you know, whenever you're using something that is a hormone, there are counter-regulatory hormones that are trying to balance the effect of that hormone. And when you now, you know, you've suppressed the counter-regulatory hormones, but if you withdraw the original hormone, those counter-regulatory hormones will then, you know, surge. So that's a problem. However, one of the other things that developments I'm seeing now is that some of the other hormones also that are affected by bariatric surgery are being discovered and they're being added onto GLP-1s to make even better medications. So I think the more recent ones have 2 incretins rather than just one, which is GLP-1, and then we'll soon have one that has 3. So these will be more effective. But again, there will be side effects like any other medication. That's a difference between those things and bariatric surgery. Also, if you withdraw the medications, the weight comes back. That's the other thing. And people also forget that even in those studies, there were lifestyle modifications that were, you know, that were taught to the patients. So it wasn't just the medication. So I think these would take their place within the, you know, armamentarium that we use in fighting obesity. But I don't think by any means they're going to completely replace bariatric surgery, because all those benefits you can get with bariatric surgery and more, because the fact that we reduce the size of the stomach and make people able to feel satiated with a small amount of food is something that those medications don't offer, that bariatric surgery offers in addition. And it's bariatric surgery is a one-time thing that you do, and you see the benefits of those hormones, you know, play out with the bariatric surgery. So everything has its place, and some surgeons actually use those medications as an adjunct to bariatric surgery for people that are super morbidly obese or people who have not have not lost weight to the extent that you would expect with just the surgery. You know, you can add the medication as an adjunct.
Good question. Good question. You know, another interesting fact about this is that obesity and elevated weight in patients, it doesn't affect the neck as very rarely. It often the cervical and the thoracic spine are not affected by this because the lumbar spine actually bears the majority of the weight of the body, and it obviously has movement to it. So it's one of those. It's sort of unique. I don't see a lot of people with weight issues and neck pain. So just sort of an interesting aside. So
I had a question,
sure.
actually, Mark.
Go ahead.
In terms of the lumbosacral spine and doing surgery there, I know that for like knees and things like that, they have weight restrictions. I'm not sure if it's imposed by insurance companies or hospitals, you know, that you can't do the joint replacements if people are above a certain BMI. Do you guys have corresponding sort of criteria for the spine surgery in terms of weight?
That's a great question. I don't believe there are any formal guidelines on that, but I will say I am very, very particular, and I will very often I will send a patient to you or to bariatric surgery first for having surgery, unless sometimes it's a catch-22. If a person is really unable to walk and they're gaining weight because they've gotten such severe spinal stenosis that they they can't even exercise to keep their weight off. Most of them they had an equilibrium. They were obese to a certain level, but they did not get worse until they had a spine issue. And then they stopped completely exercising, walking, and doing any kinds of activity, and that caused them to gain more weight. But if I'm seeing like a routine spine problem, if I don't think, they're adequately optimized, I want to send them for weight loss, either bariatric surgery or to go to their physician and go through a weight loss program.
Okay.
But
And
I
I guess
don't
that
know
makes
of any
your
formal guidelines. I'm gonna have to assign,
okay.
Maggie, can you take a look and see if there are any formal guidelines from North American Spine Society on that?
Yeah, I do know that I mean, at least 5 years ago, there was something in place for fusions and cigarette smokers, so they had to quit smoking and show a negative nicotine test at least 4 weeks prior to their fusion surgery, which I thought was very, because smoking refutes the fusion. So I know that they're on their way to do things like that because it's preventative medicine, but the weight I'll have to look into. But the
Yeah, I mean,
smoking
people.
in
Sorry, go
place.
ahead.
I was just saying the smoking like rule is definitely in place with the insurance companies, but the weight I'd have to look into.
Yeah. But I mean, I think a thoughtful physician, if you're going to be doing a spine surgery, unless it's an emergency for somebody going paralyzed or caught equina syndrome, um, you really need to, you're removing bone, you're already disrupting the physiology of the spine, and it's already a precarious situation. So you're setting that patient up for failure and a more difficult problem to fix down the road. So it's important to consider that when looking at a person with a spine problem that needs surgery, particularly for a low back pain. So the other things that it's important for patients to understand is that low back pain is a very difficult disease in and of itself to treat. There are many, many causes of low back pain. It could be arthritis, it could be disc disease, it could be muscular imbalance, it could be a number of issues, as opposed to a pinched nerve or a spinal canal narrowing where, there's no exercise or weight loss that you can do that's going to remove a pinched nerve. It's not going to release a pinched nerve. But weight loss will absolutely take the burden off of an overworked lumbar spine musculature, and it could, in many cases, obviate the need for any type of surgical intervention. If I have a patient that comes to me that they're 50 to 100 pounds overweight and it's not an emergency spine situation, if I can counsel them and get them to their primary care doctor, get them to a nutritionist, and get their weight down, a lot of times they don't need surgery.
Mm. And even if they still needed surgery, technically, wouldn't that make it relatively safer, sort of easier, more technically feasible surgery?
Yes, quicker recovery, decreased
Mhm.
chance of infection, better healing, all of the above. Absolutely.
Yeah.
Absolutely. Yeah. So how about nutrition and diet? Do you have any diet books or diets that you like to, you favor, you think is good for patients? Do you have any recommendations for our listeners to focus on the dietary side of weight loss?
Well, this is where I tell my own personal story where I myself, if you can imagine, as a bariatric surgeon, I saw my weight going up at some point. And, for me, that was a source of embarrassment, because you're doling out advice, you're doing the surgeries, and then, your weight is not, 100% under control. And that actually made me to delve deep into the uh, arena of diet. And one of the things I came across is a gentleman called Colin Campbell. Um, and I attended a course that he gives uh, out of Cornell. And that, along with several other things, some of the things I'm sure some people have seen, there's a movie called Forks Over Knives that really talks about people using diet, You guys are smiling like you've watched that.
Well, I
You-
always call the exercise I most need to do are called fork put downs.
I hear you on that one.
I only
Yeah.
laughed because I knew something along those lines was what he was thinking.
The fork put down. That's a good one, Mark. Yeah. So I watched that movie, and that movie opened my eyes. It opened my eyes to a number of things. It opened my eyes to the fact that, your body is always trying to heal, your body is always trying to repair, and really what the situation is in a lot of our society is that with what we're eating mostly, there are chronic diseases that are associated. And one of those chronic diseases is also obesity. So if we remove the things that we're eating that are causing these diseases, that are causing the obesity, your body actually can heal to a large extent. Okay. And then if you then focus on eating certain things that are a lighter calorie load than, a lot of the processed things we have that are mostly plants, then you will thrive. And I found this was buttressed by looking at certain communities that followed certain eating patterns, right? Especially places called the blue zones, right? Okinawa in Japan, uh, Nicoya, and Santorini in Italy, and even Loma Linda in the United States, believe it or not, amongst Seventh-day Adventists. And looking at their patterns of eating, it's kind of rang true, even though they ate very different things. The main concept was about eating mostly plants and about eating mostly whole foods that had not been processed. Right. So that is what I followed. And based on that, actually, I was able to lose 40 pounds, which, helped me tremendously in terms of how I appeared to patients. Patients, it's a good thing when patients can notice that their bariatric surgeon has lost some weight. Also, I was able to reverse high cholesterol that I had. And then my pre-diabetes, where my A1C was already trending up to like 6.7, I was able to bring that down to 5.3 based on diet alone. So I'm a firm believer in what we call a whole food plant-based diet. And I know that because of cultural pressures, not everybody can go all that way. But I also recommend diets that are similar to that, just to give people different choices. If they can follow this, that would help them on their weight loss journey, not only to lose weight, but also to gain health. Other diets like DASH diet that have been scientifically proven to reduce high blood pressure and to help people lose weight. Other diets like Mediterranean diet, right, which kind of similar as well and also been scientifically proven. So these are the kinds of diets that I recommend to patients.
What are your thoughts on intermittent fasting?
Oh, I believe in it. The science is solid. There's two main benefits. There's something called metabolic switching your body's metabolism from burning sugar to burning fat, is a real thing that has benefits, health benefits, as well as weight loss benefits, and those have been proven. And then what's the other thing? The other thing is autophagy. When you fast past 12 hours and your body is depletes the glycogen in your liver, your body, it also switches on this process called autophagy, where at the cellular level, there are organelles that go around sort of scavenging dead and dying cells and recycling them into new proteins. So that is also has a lot of benefits. It's been shown that it helps to eliminate neural tangles that have been implicated in Alzheimer's. It helps, glucose metabolism. It helps fat metabolism. It even helps the wound healing process. And there's studies that have shown that wound healing goes on better and wounds heal faster in people that are actually doing some fasting other than people that are, eating regularly. So I do a version of the intermittent fasting where I fast for like a 16-hour period, and within an 8-hour window, I try to have my meals during the day, especially like 5 days a week during the work week. And during the weekends, I give myself a break from that. And yeah, there's benefits from that have been shown scientifically.
Autophagy, is that how you spell it? Say
Yeah,
it. Autophagy.
autophagy literally it's Greek meaning eating
Eat.
yourself. Yeah, the picture I have in my mind of autophagy is like Pac-Man. If you
Yeah.
remember Pac-Man, yeah. So it's a cleanup system. People talk about, I want to do a cleanse. I want to do a cleanse. The scientifically proven kind of cleanse you can do for your body is to fast, because you switch on the autophagy and essentially it's cleaning up dead and dying tissues. It's recycling them into new protein. So you don't only get protein, you don't necessarily only get protein from what you eat. Your body can recycle, protein.
Yeah, it's like
Interesting.
I actually was reading into this the other day. It's like our natural, healthy way of apoptosis. It's like the good apoptosis, if you want to think about it. Scientific way.
Yeah.
Nice.
Yeah, it's exciting because, it's only, I think, in like 2016 or so that this kind of made a resurgence with new research that was being done. There's a guy, I forget his name now, the Dr. Osumi or so from Japan that got a Nobel Prize on this in 2016. And that is where autophagy came back, and people are talking more about it and its role in intermittent fasting and all that.
Gotcha. We got another question that came in. Is it harder to do back or spine surgery on someone very overweight? And my father needs back surgery but weighs 265 pounds, which he says in quotation marks, and is 5'6". So I would say, JJ, yes, back spine surgery is harder to do in people who are overweight. 265 with a 5'6". I don't know what body mass index that is. Like, I'm not a good in math, but it depends on what he has. Yeah, it depends on what he has. It's higher than, ideal. And he may still be a candidate, or it may be something that we ask him to lose some weight before we consider him a surgical candidate. So something should be assessed. But like I would say, if there's something pressing on the spinal cord or on the nerves, he would most likely be a candidate for surgery at that weight that you describe. So, Maggie, Brian, are we getting any other questions? I want to be respectful of everybody's time, especially Dr. Sean's time. Do we have any more?
Not that I can see, but I just have one quick thought and question. So something that I feel with just society in general, and Dr. Sean and Dr. McLaughlin, let me know how you feel. I kind of compare it to alcohol. I don't know, like when you go out to eat or to drinks with your friends and you don't choose to drink, and people are always like, oh my gosh, why aren't you drinking? There are times where I found myself in my life where like I'm not hungry, so I don't have that appetizer. I don't we're watching football games and someone wants to cook appetizers and everyone wants to eat the buffalo chicken dip and I'm just not hungry, so I don't want it. And I feel like a lot of the time society also is the same way with alcohol, that they are food. Like, why aren't you eating that? Oh, why did you not, why'd you get a Caesar salad instead of like the filet mignon? Do you guys ever like notice that too?
Yes. Yeah. It's the age-old controversy of popularity or effectiveness. Which one would you rather be, effective or popular?
Because
Yeah.
I have no problem with saying like I'm not hungry, that's why I didn't eat it. But people are like, you're not gonna have a chip? I'm like, no, because I won't eat unless I'm hungry, which I don't know. I don't think there's something wrong with it, but
Maggie, I must tell you, that is a good kind of philosophy to have if you're someone that can, that you eat based on just when you're hungry.
Yeah.
That is a natural sort of way that a human being should be, not recreative eating like we practice a lot now, which is what you're talking about, because you're out with friends, because, for social reasons and all that kind of thing. It's part of the reason we have the issues we have. And, the strength of those forces is so great. And that's what you're expressing, that it's difficult to negate them. There's studies that show that how you eat, what you eat depends to a large extent on what the person sitting across from you on the table is eating. So all these forces, these social forces, have an impact. And it's one of those things that we have to contend with in today's society. As I say, nobody is coming to save you, so you have to save yourself. So the starting point is to learn all these things, make a note of them, understand that, the norm in society may not support, you being able to eat a diet that would, have you lose weight and be a normal weight. And then you need to have strategies that help you to navigate the world where you can eat healthy so as to be, healthy and have a optimal weight.
We have one more question for you, Dr. Seun. It's from Lisa, and her question is it okay to fast if you've had gastric surgery?
Yeah. So the answer to that is yes, but I'd like to qualify that, so there's some kinds of fasting that require medical supervision. The kind of fasting I described, where you're doing a 16-hour fast and then 8-hour feeding window, on a daily basis for a few days a week, that does not, in my mind, require any medical supervision unless you're sort of like a brittle diabetic or something like that, But some other kinds of fasting that people do, if you're going to fast like more than 24 hours straight, 48 hours, 72 hours, which people do, then I would suggest that, you be medically supervised, at least, get your own physician to look at, to weigh the risk and benefit of that against your personal medical profile. Yeah. But I encourage my patients who've had gastric surgery, gastric sleeve, gastric bypass to actually do the intermittent fasting, either 8 hours feeding window or even 6 hours feeding window for some of them, and, the fasting period.
Excellent. Well, this has been a great conversation, Dr. Seun. I really appreciate your time. And for the listeners, please send us some messages. This was kind of an experiment, our first time having a conversation like this. Tell us what you want to hear, and we can discuss it in the future. I want to thank Brian Greer, who did a yeoman's job to get this out there and broadcast on multiple platforms. And Maggie, thank you for helping out as always with the slides and with the great questions and insights. And thank you all for attending. And we hope to see you again in the future. And please give us some feedback on whether this was worthwhile for you and what you'd like to see in the future. Dr. Seun, thank you again so much for your time.
All right. Thank you, Mark. I learned a lot. Thank you, Maggie.
I did too.
There as well. And it's been fun as well. So I hope some people have gained something from this. And as you said, let's have some feedback. Let's know if there's anything we can address to help people to lose weight, to live a healthier life and gain health.
Amen. Thank you, sir.
All right.
You.
Good night,
Thanks.
everybody.
Good night.
Everyone.